Welcome to the August 2023 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. Today, we are featuring the content of the August 2023 issue. My name is Mike Rickles from the University of Pennsylvania.
And I'm Alice Chang from the University of Toronto. As per usual, Mike and I will be interviewing authors of feature articles as selected by the editors of Diabetes Care, followed by our rapid exchange segment, where we give brief summaries of articles we found of particular interest.
Well, Alice, we are well past the halfway point of our first year with this podcast series. Any thoughts and reflections so far?
I've had a blast so far, recording these podcasts from my closet, literally. I've really enjoyed the opportunity to chat with different authors from around the world about their work. No matter the topic, the common theme has been every author's passion for their research and enthusiasm to share their work with the world. And it's always interesting how they try really hard to keep within the short time that we give them. But I have a feeling that given the opportunity, they could probably talk for hours and hours about the topic. So I've learned a tremendous deal from them. How about you, Mike?
It's been really fun for me too, and I've had a terrific time working with you, Alice. You and all the authors I've interviewed have taught me a great deal and have really made me think about diabetes from so many new perspectives. I do hope that feeling of learning that you've commented on and that I've experienced is really being shared by our listeners through this program.
Couldn't agree more, Mike. And it's been a pleasure working with you as well. And I look forward to many more years of this. So let's get started and dive into the feature interviews for August 2023.
In the August 2023 issue of Diabetes Care, one of the feature articles is a review entitled "The Growing Role of Technology in the Care of Older Adults with Diabetes." This review stems from a workshop of experts in diabetes and geriatrics from the International Geriatric Diabetes Society that convened to evaluate current evidence for the impact of diabetes technologies in older adults and to identify future research priorities. I'm delighted that the article's first author, Dr. Elbert Huang, has joined us to discuss this very important topic we are all navigating in our own clinical practices. Dr. Huang is professor of medicine and of public health sciences at the University of Chicago, where he serves as director of the Center for Chronic Disease Research and Policy. Welcome, Elbert.
It's nice to meet you, Michael. Thank you for having me.
Congratulations to you, Elbert, and to your colleagues on this feature article. Your article has three main objectives. First, to identify major barriers to the use of existing and emerging technologies. Second, to identify areas of care amenable to optimization by use of technology. And third, to identify areas for future research. So, Elbert, can you start by explaining how aging, diabetes, and technology relate differently for our older population with diabetes than for younger adults?
Right, happy to do so. So first, we have to start by saying that diabetes in older adults, in terms of its natural history, in terms of people's reaction to medications, the goals of care even, are different in older people compared to younger adults. And part of that has to do with the underlying heterogeneity of the older adult diabetes population. Compared to younger people, older adults are more likely to have other comorbid conditions. Some of them may have actually already experienced the complications of the disease. And there may be other sort of geriatric related conditions such as falls, urinary incontinence, cognitive impairment that come along as we get older. The population is more heterogeneous with more complexity. I'd also like to make the point that older people that we see with diabetes, many of them are the survivors of their generation with diabetes. So the average duration of diabetes, for example, is actually 10 years or more once you're encountering somebody in their 60s, 70s, or 80s who's had diabetes. So they're at a different time point with their diabetes compared to a younger adult or a middle-aged adult. There is a fraction of older adults that has relatively new diabetes. It's a minority. And that presentation of diabetes also tends to be basically less severe, milder than the presentation of diabetes for a middle-aged adult with type 2 diabetes. Let me also just say that there are both patients, older adults with type 1 and type 2 diabetes, and we are increasingly seeing, due to the success of our new therapeutics and treatment programs, there are increasingly many older adults who have type 1 diabetes for a very long duration of diabetes, going back to their childhood or young adulthood. On top of that, as older adults progress through their lives, many of them need a caregiver to help support the delivery of diabetes care, not too different from the need for a child with diabetes to have a parent as a caregiver. So in many older adults, as they especially acquire functional impairment, will need help in monitoring their glucose levels, administering medications, and will need assistance in many other areas of what we call activities of daily living. And then with regards to technology and its role in older adults compared to younger adults, there are basically generational differences in comfort levels with technology. So the older adults of today will not be the same as the older adults of tomorrow. So of course, there will be generational shifts in comfort levels with technology. But the current older adult population that's made up of the greatest generation, many baby boomers right now, their level of comfort with technology is different than for Generation X or younger generations. So that's a factor in the role of technology in diabetes management in older adults right now.
So when it comes to technology, we already know there can be a lot of barriers to the implementation of technology use, both for our patients and for our clinical practices. What do you see as the most important barriers for technology uptake and use for our older patients with diabetes?
There broadly are three main areas of barriers. Some of them reside with the older patient. Some of them are with our clinicians who care for the older adults. And then I think we have a number of policy barriers to technology adoption in this population. So first, let's take the older adults. There are a number of structural issues that make the comfort level and the facility to adopt technology harder for many older adults. Some of this actually has to do with, honestly, relates back to structural racism, actually. There are parts of the country, for example, that have limited access to technology such as internet broadband. That access is variable across the country, that going back to housing policies from decades ago. So there are some older adults living in areas that have limited access to technology. There were educational differences among some older adults that create differences in technology literacy. So we've moved on from thinking about not only health literacy, but now moving on to thinking about technology literacy. And technology literacy tends to be at lower rates among older adults. Some of this going back to these educational differences that they experienced when they were younger. And many older adults need assistance when they are adopting technology. So this has a lot to do with, they're more likely to adopt it if there's someone in the family who can help them. Those are kind of the issues and barriers that relate to older adult adoption of technology. It's the older adult, but it's the surrounding neighborhood. It's also the family and the caregivers. Older adults, for the most part, are cared for by primary care physicians. So this gets to who takes care of older adults. We simply don't have the numbers of endocrinologists to provide diabetes care, have endocrinologists care for every single older adult. So most care relies on primary care providers. And some of those primary care providers are not comfortable with diabetes technology, either pumps, continuous glucose monitoring, certainly not comfortable with closed loop systems or hybrid loop systems. There is a drop-off in sort of expertise and a great need for education among the providers that care for most older adults with diabetes in the United States. There are some settings where there is a really desperate need for more technology savvy and education among the providers. And the one setting I'm thinking about is, of course, long-term care. Long-term care has really basic problems where sometimes the staff are unable to distinguish between type 1 and type 2 diabetes. And this leads to sometimes catastrophic situations where a person who needs insulin to live doesn't get insulin. And so you can imagine also if there's major deficits in education around just distinguishing different forms of diabetes in long-term care, we have similar problems with facility and comfort with diabetes-related technology. The last area, of course, is policy. So the vast majority of older people, because of the way that healthcare has been designed in the United States, are covered by Medicare. So Medicare policies related to coverage of technology is really important for whether or not it's going to be affordable for the older person. And so many of your listeners may recall that just a couple of years ago, to order continuous glucose monitoring required going through some pretty onerous bureaucratic steps. The requirements for continuous glucose monitoring have been lowered to make it easier to acquire, but it's still a challenge to find a device provider who can navigate the Medicare rules and regulations to get a device covered. So those are sort of the major categories of barriers.
And so, Albert, considering those barriers and also the potential, which you discuss as well in your article, that there are particular areas where adding technology use may be particularly important for helping the care of individuals such as those with cognitive impairment or residing in long-term care facilities. And so if we were to try to target a prioritization of education around technology that have the biggest impact in this population, where do you see making first steps or a few examples on where we might prioritize technology adoption for this vulnerable population?
So I think while this population is a minority population of the older adult population, clearly the group that's most likely to benefit from continuous glucose monitoring, insulin pumps, closed loop systems or hybrid loop systems is going to be the type 1 diabetes older adult population. This population is most likely to benefit almost immediately. And they are actually the ones represented in clinical trials of the devices. So one particular setting where I think an educational effort or research efforts around encouraging more adoption of technology would be in long-term care. So one of the interesting aspects of technology adoption in this setting and in this population is that, we think classically of diabetes as having the goal of lowering blood sugars to reduce complications. But technology in this particular setting or in the older adult population is going to have actually a different set of goals, but equally important for the quality of life of a person. And it is actually to avoid hypoglycemia. And increasingly, we're learning about the value of keeping blood sugars within a targeted range. So education and uptake of technology in long-term care for people with type 1 diabetes, would require a multi-level approach, not only addressing kind of the medical directors, but also the frontline staff that care for these patients, and educating at all levels to encourage adoption of these devices, I think could have a huge impact on the quality of life of older adults. But there are, of course, open questions about whether or not keeping the sugars within ranges ultimately reduces things such as falls, infections, and other complications that are really important to older people.
Yeah, I fully agree with the hypoglycemic avoidance and the ability to program alerts and alarms that now many people on CGM have the capability of sharing that data with family members, loved ones, partners, even providers who may then be able to step in and assist if low glucose is detected. And so the potential there to expand that beyond the personal use, but into an institutional use for monitoring patients with diabetes that can be done then essentially remote monitoring and not require a physical assessment with a point of care glucose determination in order to track someone's glucose trajectory, I think could be huge.
Thank you for bringing that up. Yeah, one of the potential side benefits that are not directly for the patient, but actually for potentially the care team, both in long-term care and potentially in the hospital as well, is that remote monitoring with continuous glucose monitoring could reduce the number of contacts that we require with traditional glucometers, which actually might have infectious disease, reducing benefits, and might actually reduce workloads for some frontline staff. So there are many questions about technology and the potential future state where we could potentially monitor many patients at the same time and anticipate problems before they happen.
That's great. And I wanted to come back to what you mentioned about technology literacy, and your article discusses digital literacy, e-health literacy, and as well technology confidence. And so as you know, we have this problem with technology widening disparities in care, and these are certainly critical areas, but are seldom assessed in clinical research. How can we best incorporate these assessments, and what future research is really needed to make sure we're addressing these issues?
I think one of the basic starting points is to begin measuring these different forms of technology or digital literacy, just as we did with health literacy a couple of decades ago. And that starting point can lead to the design of interventions to see if we can move the needle on literacy. It can be a way to even stratify populations and maybe target programs differently depending on baseline literacy. And also, it's a way to determine whether or not there are certain kinds of technologies that seem to be more amenable across the literacy spectrum. In prior work people have done around technology and diabetes, for example, one technology platform that seems to have potential for great reach is mobile phone technology, which everyone seems to have a smartphone. So I think that's at least a starting point. But it'll be fascinating to see what happens, especially with the relatively new infrastructure law passed by the Biden administration, which includes expansion of broadband access to hard to reach populations in not only inner city America, but rural America. And it'll be fascinating to see if that helps with expanding access to technology for different populations. So I think it's a really rich, exciting area, and that is primed for much more research.
Terrific. And Elbert, any final takeaway messages for our listeners?
I would just say that we're living in a really exciting time where we have these exciting technologies such as continuous glucose monitoring, insulin pumps, closed loop systems, and they really have the potential to improve the lives of our patients. We just have to remember that nearly 50% of the diabetes population is older. And so we don't want a situation where we leave this very large, oftentimes vulnerable population behind as we race ahead in developing new technologies. So it's just a call to action for policymakers, researchers, and practitioners to come up with new ways to encourage adoption of diabetes technology.
And make sure it's accessible to those that may not be as nimble as they once were.
Right, exactly. And we're doing this all for ourselves as we are all going to age and become, one of these older people. And so we want to, prepare the future for ourselves. Yeah, we want things to be accessible, but also efficacious.
Well, thank you, Dr. Huang. I really appreciate your joining us today. I know that I've learned a lot about the challenges and opportunities for technology use by older adults with diabetes. And this should, again, as we've talked about, ultimately be implemented with the goal of improving quality of life, and especially for those individuals whose autonomy may be limited. And I encourage our listeners to please access the full article in the August issue of Diabetes Care. And thank you for tuning in.
One of the feature articles from the August 2023 issue of Diabetes Care is titled Metformin versus Insulin and Risk of Major Congenital Malformations in Pregnancies with Type 2 Diabetes, a Nordic Register-Based Cohort Study. I am joined by the first author, Dr. Lars Kjerpeseth. And I apologize, Lars, I'm sure I mispronounced that. And I apologize to everyone in Norway as well for that, who is an epidemiologist and public health scientist at the Norwegian Institute of Public Health in Oslo, Norway. Welcome, and thank you for being part of this podcast.
Thank you. It's a pleasure to be here.
So congratulations to you and your colleagues for this feature article, which is quite an accomplishment. When I first read the title of the study, I have to admit, I naively thought that this wasn't really necessary because I figured that the safety of metformin had already been established with randomized controlled trials like the MIGHTY study, for example. But as often happens with me, I was obviously wrong. So why was it necessary to conduct this cohort study? And what did it bring that was unique?
We were concerned that RCTs like the MIGHTY trial have not been able to adequately investigate the risk of major congenital malformations with metformin in pregnancy because of small sample sizes, since it is a relatively rare outcome, and because in trials, randomization to metformin typically occurs after the first trimester, which is when major organs are formed and are most sensitive to the development of congenital malformations. Our study was unique in that we investigated the safety of first trimester metformin exposure with insulin in pregnant women with type 2 diabetes. And due to its size, drawing on data from 4 Nordic countries, which meant we were able to assess not only malformations overall, but also cardiac malformations, which is the organ system most often affected by malformations.
Okay, very interesting. So yeah, it does answer some questions that RCTs like MIGHTY may still have left unanswered. So then how exactly did your group conduct the study?
We pooled data on all live and stillbirths in Iceland, Norway, Sweden, and Finland in the last 2 decades or so, which was then analyzed as one cohort. And using the personal identity number unique to all residents in the Nordic countries, we could link data on mothers and children in the birth registers to other nationwide registers, such as for prescriptions and specialist healthcare. We then compared the risk of any and cardiac major congenital malformations in infants exposed to metformin in first trimester, either alone or in addition to insulin, with insulin alone. We excluded pregnancies with other indications such as polycystic ovary syndrome and assisted reproductive treatment to minimize confounding by indication.
So then what were the main findings then? What did you and your group find?
Of the 3.7 million infants in the source population, we included 4,023 singleton infants. And of these, 3,145 were exposed to metformin and 878 to insulin alone. And 4.7% in the metformin group and 5.7% in the insulin group had a malformation, while 3.0 and 2.1% had a cardiac malformation. After doing several analyses where we adjusted for confounders, limited to subgroups, and did several sensitivity analyses, we concluded that the evidence did not point to an increased risk of cardiac malformations with metformin compared with insulin.
So I have to say that's certainly a sigh of relief from me, and I suspect many other clinicians listening, because we have been using metformin in these ladies, and it's always nice to have some more data for reassurance. Now, you already mentioned this briefly, but could you maybe give us a few examples of the sensitivity analyses that your group did? Because as I was reading your paper, that was one thing that struck me, was that you were very careful and went to great lengths to minimize confounding and performed a number of these sensitivity analyses. So can you give us a few examples and what made you decide to do this?
We know that high glucose levels increase the risk of malformations, and therefore it is difficult to disentangle the teratogenic effect of diabetes from a potential teratogenic effect of metformin.
Mm-hmm.
One of our limitations was that we did not have information on glycemic control. So one of the sensitivity analyses we did to disentangle the effect of metformin from diabetes was to compare a metformin treatment with no metformin treatment in mothers with polycystic ovary syndrome and no pre-gestational diabetes. We also did high-dimensional propensity score analysis to identify potential proxies for unmeasured confounders, such as glycemic control, to explore the impact of these on the absurd associations.
Now, almost all of your analyses did not show an increased risk of malformations associated with metformin compared to insulin. But in one of the sensitivity analyses looking at infants of mothers with a recorded type 2 diabetes diagnosis, metformin was associated with an increased risk of cardiac malformations versus insulin alone. Now, as a clinician, I mean, that concerns me. I realize it was one of several. So tell me, what does that mean? Should I be worried? What should we do with that information?
I'm not too concerned with this finding. I think it's due to residual compounding or selection bias in that particular analysis. In this analysis, we saw that exposure to metformin was associated with twice the risk of cardiac malformations compared with insulin alone. However, there were only 7 cases in the insulin group, and the result was not statistically significant. And when we did a corresponding sensitivity analysis for any malformations, we did not see an increased risk with metformin. In one of the main analyses, we also found a moderately increased risk of cardiac malformations with exposure to both metformin and insulin compared with insulin alone. But again, the result was not statistically significant. And the other analysis on cardiac malformation did not suggest harmful effect of metformin. And we think that if metformin truly increased the risk of cardiac malformations, we did be more consistent across most of the analyses we did.
Okay, thank you. So again, we should be reassured and not worried, which is a good thing. So finally, how would you like to see these data from this cohort study be used by clinicians and or policymakers?
I think it's a reassuring study for clinicians and patients, since malformations are one of the major concerns when using drugs in pregnancy. And due to its size, I think it's an important study for policymakers to consider for guidelines on treatment of diabetes in pregnancy.
Thank you very much, Dr. Kjerpeseth, for sharing your expertise with us today and sharing highlights of your study. I have to say that this gives me peace of mind, as I, for one, have used a lot of metformin early in pregnancy and type 2 diabetes. And we all know the importance of glycemic control at that early stage. So it's reassuring to know that this is a tool that we can safely use. So thank you. Thank you again. And I encourage the listeners to read the full article in the August issue of Diabetes Care.
Let's move on now to our Diabetes Care Rapid Exchange, where Alice and I chat about some of the articles we found particularly interesting this month.
Let's do it.
Okay, Dr. Catherine McCarthy from the Icahn School of Medicine at Mount Sinai, New York, and colleagues examined the racial and ethnic influence on risk of diabetes and glycemic control for women with a history of gestational diabetes using a large multi-ethnic population-based cohort of postpartum women. Expectedly, the cumulative incidence of diabetes development was 11.8% for women with and only 0.6% for women without a history of gestational diabetes. Interestingly, this increased risk for future diabetes conferred by a history of gestational diabetes did not differ by race or ethnicity. However, the time to achievement of glycemic control once diagnosed with diabetes was significantly longer for Black and Hispanic women. Thus, this article points out that among women with a history of gestational diabetes, there is a need for culturally tailored interventions to impact the existing disparity in diabetes progression.
Yeah, I noticed this paper as well, Mike, and those numbers of 11.8% for those women with and 0.6 for those women without. If I'm doing the math right, I think that's about a 20 times difference, right? I hope I'm doing the math right.
Huge increase in relative risk.
That's quite substantial. And I think important that we obviously identify these women and treat accordingly, exactly as you had said. So thank you for that. Dr. Ruchi Sharon and colleagues, under the leadership of Dr. David Campbell from the University of Calgary in Alberta, Canada, performed a propensity-matched cohort study using administrative health data from Ontario, Canada, to investigate the rates of diabetes complications and revascularization procedures among people with diabetes who have experienced homelessness, compared with a matched cohort of non-homeless controls. Now, looking at 5,219 matched pairs, the rate of macrovascular complications was higher for people with a history of homelessness, with a relative risk of 1.85. Rates of hospitalization for glycemia were significantly increased, with a relative risk of 5.64, and skin or soft tissue infections was increased significantly, with a relative risk of 3.78. Interestingly, though, the rates of coronary revascularization procedures were lower for people with a history of homelessness. Now, I think this is a stark reminder of the importance of the social determinants of health and the impact that it has on overall health, and certainly with diabetes and diabetes complications. And the authors concluded that these higher rates of complications present an opportunity for tailored interventions to mitigate these disparities.
And so we see again a tremendous need for novel approaches to care implementation for the most vulnerable members of our population. And at the same time, we see in the August issue 2 articles investigating GLP-1 agonist intervention on kidney disease-related outcomes in type 2 diabetes. Dr. Beatty Botros from Eli Lilly and colleagues conducted a post-hoc analysis of the REWIND trial that randomized almost 5,000 participants to each of a dulaglutide and a placebo arm. Kidney function-related adverse outcomes and decline in estimated glomerular filtration rate were significantly lower with dulaglutide, an effect most pronounced after 3 years of drug exposure. And Dr. Hiddo Heerspink from the University of Groningen in the Netherlands and colleagues conducted a post-hoc analysis of the SURPASS-4 trial that randomized almost 1,000 participants to each of a tirzepatide arm and an insulin glargine arm. Here, the decline in estimated glomerular filtration rate was also significantly less with tirzepatide after 52 weeks. Together, these studies add to the evidence base for kidney protective effects of GLP-1 agonists used in the treatment of type 2 diabetes.
And I think all of us eagerly await the results of sort of dedicated renal studies, prospective studies with GLP-1 receptor agonists, like the FLOW study with semaglutide. So I think this sort of adds to the excitement. Now, a challenging clinical issue that I think all of us encounter is that of glucocorticoid-induced hyperglycemia. Dr. Aaron Deutsch and colleagues, under the leadership of Dr. Laura Brenner from the Mass General Research Institute, performed a retrospective analysis to determine whether a type 2 diabetes global extended polygenic score could predict who would develop glucocorticoid-induced diabetes. They looked at 552 individuals who received glucocorticoids and found that the polygenic score was significantly associated with glucocorticoid-induced hyperglycemia. The odds ratio was 1.5 per standard deviation of the polygenic score. This finding offers a method for risk stratification when making decisions around glucocorticoid treatment and a precision approach to medical treatment.
Very impressive, and particularly since we just heard from Dr. Deutsch and colleague Dr. Miriam Udler during the April podcast episode about the use of polygenic risk scores for type 1 diabetes to improve the accuracy of diabetes diagnosis for non-white individuals. So I really do hope that we see soon these genetic approaches incorporated into diabetes practice. Now, youth onset type 2 diabetes has been associated with progressive loss of beta cell function. And Dr. Kristen Nadeau from the University of Colorado and colleagues from the Today study examined whether early glycemic control affected beta cell function using oral glucose tolerance test data from 656 participants who had on average over 6 years of follow-up in the Today study. And while early tight glycemic control was associated with those individuals who initially had greater beta cell function, over time, all individuals experienced deterioration in insulin secretion. And so these results really point out the necessity and also the urgency to identify disease-modifying interventions for youth-onset type 2 diabetes that go beyond just reducing glucose levels in order to ultimately improve longer-term metabolic outcomes.
Yeah, I really like that thought of disease-modifying therapies, right? I mean, that's certainly something that they discuss in other therapeutic areas, like rheumatology, for example. And I feel like it's high time that in diabetes, we're able to make such statements. So thank you for that, Mike. My final pick is looking at the prevalence of polyneuropathy in type 2 diabetes subgroups based on HOMA2 indices of beta cell function and insulin sensitivity. Fredrik Christensen and colleagues from the Aarhus University in Denmark estimated beta cell function and insulin sensitivity in about 4,400 Danish patients with newly diagnosed type 2 diabetes. Utilizing HOMA2 indices, they categorized these patients into subgroups of hyperinsulinemic, classical, and insulinopenic. After a median follow-up of 3 years, patients completed the Michigan Neuropathy Screening Instrument questionnaire to identify diabetic peripheral neuropathy. Now, the prevalence of diabetic peripheral neuropathy was 23% amongst those who were categorized as hyperinsulinemic, 16% amongst those who were considered classical, and 14% amongst those who were insulinopenic patients. Now, the adjusted prevalence ratio of diabetic peripheral neuropathy was 1.35 for the hyperinsulinemic group compared with the classical patients. Now, these data, I think, will allow for better prediction of who is more likely to develop diabetic peripheral neuropathy.
Yeah, I found this paper so interesting, Alice. The hyperinsulinemic group was the most insulin resistant, but hyperinsulinemia per se held up in the risk analysis for diabetic peripheral neuropathy after adjustment for insulin sensitivity and metabolic syndrome traits. And so this brought to mind for me those rare cases of treatment-induced or so-called insulin neuritis. And I wonder whether there may be similar mechanisms at play. So one last item is a reminder to everyone listening to please let folks around you know about the opportunity to submit their original art for consideration to be included on a future cover of Diabetes Care. And of course, a big thank you to all of you for tuning into this episode. Please share your comments and feedback, and don't forget to subscribe to this series in order to get notifications when a new episode comes out. Thank you so much for listening.